Etiologies of the optic neuropathy are papillary edema, glaucoma, inflammatory disease optic neuritis, vascular condition, radiation optic neuropathy, compressive or infiltrative lesions, hereditary condition, toxic substances and nutritional deficiency, trauma, congenital optic nerve head anomalies, and the optic disc bruising. Papillary edema, optic nerve head edema resulting from the increased intracranial pressure leads to papillary edema. The causes are hydrocephalus, meningeal processes like infection of CNS, or infiltration by the granulomatous or the neoplastic processes, increased venous pressure from the cerebral venous thrombosis, venous sinus stenosis, or the dural fistula, idiopathic intracranial hypertension. Acute papillary edema is characterized by the hyperemia of the optic nerve head with dilatation of optic nerve head surface capillary network and the radial peripapillary vessels, greenish whitish opalescent thickening of the peripapillary retinal nerve fiber with feathered striated margin, and the obscuration of the optic nerve head edge and the vessels is seen. Cotton wool spots, exudate, and hemorrhage is seen. Late findings shows the absence of physiological cough and the obscuration of the vessels in the optic nerve head. The figure shows the bilateral papillary edema with the blurring of the disc margin with feathery striated margins and flame separate hemorrhages and the obscuration of the optic nerve head optic nerve head edge with blood vessels torsity. Oblique papillary edema is characterized by the normal visual acuity and the color vision with enlarged blind spot, whereas chronic papillary edema is characterized by the pale optic nerve head due to chronic axonal loss, glycis of retinal nerve fiber layer, grayish, less fluffy, membranous with vascular sheathing, as seen in the figure, optociliary shunt vessels and the refractal bodies of the optic nerve head. As seen in this figure, the vascular sheathing and the pale optic nerve head is seen, and whereas the lower figure shows the refractal bodies that is differentiated from the optic disc drusen by the as it is the non-calcified. Urgent MRI of the brain and orbit with contrast medium is done, and MRV is done to rule out the intracranial as well with cerebral venous thrombosis. If they are normal, prompt lumbar puncture for the CSF opening pressure and the evaluation and composition should be done. Idiopathic intracranial hypertension, also known as pseudotumor cerebri, is characterized by the increased signs symptoms of increased ICP. Headache is common, neck and back pain, transient loss of vision, diplopia secondary to cranial nerve 6 palsy, cranial nerve 7 dysfunction, pulsatile tinnitus, that is synchronous group, and the nausea is common. It usually peaks in third decade of life, and 90% are women and 90% are obese. The figure shows the retrobulbar optic neuritis. ONTT trial have shown that the optic neuritis reoccurs in the affected or in fellow eye in 35% of cases and overall, and in 48% of patients with conversion to multiple sclerosis. Corticosteroid therapy for more reasons. Oral prednisolone shows no improvement in vision, and their recurrence rate was twice as high as that of other groups, so it is not recommended. Relapsing and remitting form of multiple sclerosis, immunomodulated therapy has shown to decrease the relapse. All typical features are associated with old age, lack of pain or persistent pain or vision loss, significant swelling of the optic nerve head with peripapillary hemorrhage, exudate, inflammatory ocular features, bilateral vision loss, involvement of other cranial nerves, straight optic neuropathy, straight responsive optic neuropathy, and lack of vision recovery by 1 month. In all these cases, the other etiologies should be ruled out. The other optic neuritis are the neuromyelitis optica and the neuromyelitis optica spectrum disorder, and the myelin oligodendrocyte or glycoprotein IgG associated disorder. In NMO, it is characterized by the optic neuritis and transverse myelitis, also known as David disease, with positive aquaporin P4, IgG, redox, phenolate mofetal, or the periodic intravenous immunoglobulin has seemed to decrease the recurrence and disability. Neuroretinitis is characterized by the loss of vision associated with optic nerve edema and star pattern in macula. There is associated mild vitritis and choroidal lesion. The diffuse optic nerve edema spreads over the outer plexiform layer around the papillomacular bundle and around the fovea. Usually it is also infectious or post-viral autoimmune process, frequently associated with increased immunoglobulin M antibody titer for Bartonella cuneata and the Bartonella hensleyi to rule out catastrophic disease. Other causes are Lyme disease, sarcoidosis, syphilis, toxoplasmosis, tuberculosis, and other viral infection. No definitive evidence has shown that the corticosteroid or antibiotics beneficial effect on the visual outcome. On vascular optic neuropathy, anterior-ischemic optic neuropathy, it is the most common acute optic neuropathy in patient more than 50 years and patient present with painless monoocular loss of vision that develops over hours to days. Visual acuity may be relatively preserved with RAPD unless it is bilateral. Optic nerve edema at onset, which may precede the vision loss. The visual field loss is seen as altitudinal or arcuate, or any other field defect may be seen, can be either arteritic or the non-arteritic form. Talking about the non-arteritic anterior-ischemic optic neuropathy, it comprises 90 to 95% of AIN, total AIN cases, and presumably it is related to the compromised optic nerve head microcirculation with structural crowding of optic nerve head. The course of the vision may remain static, that is stable vision loss from the onset, or progressive episodic stepwise decrement or steady decline over few days to few weeks before eventually stabilization. The first figure A and B shows the NAIN features. In A, the healthy eye demonstrates the characteristic crowded appearance, which is called as the Dixat risk, and B shows the affected optic nerve head appearance in NAIN, in which the edema is segmental with mild superimposed pallor and the flame-separated hemorrhages. Non-arteritic AIN is associated with following risk factors like structural crowding of optic nerve head, which is also known as Dixat risk, diabetes mellitus, particularly in young patients, systemic hypertension, hypolipidemia, obstructive sleep apnea. Non-arteritic ischemic optic neuropathy, if there is occurrence in the second eye in which the previously affected eye optic nerve head is atrophic and currently optic nerve head is edematous, it is known as pseudo-Foster-Kennedy syndrome. And in true Foster-Kennedy syndrome, one optic nerve head is atrophic because of chronic compression by the mass, whereas the other optic nerve head is edematous because of increased ICP. In this figure, the optic nerve head is in true Foster-Kennedy syndrome is seen. Unlike the NAIN, the edematous optic disc is usually hyperemic with normal visual function, and the contralateral eye shows pallor with no altitudinal pattern of atrophy. Treatment, generally vision remains stable after it has reached to its lower point. There is no proven therapy for the NAIN. Ischemic optic neuropathy, decompression fenestration had no benefit in NAIN. Steroid or neuroprotective drugs are also not recommended. There is increased risk of cerebral ischemic stroke, so the patients should be referred for risk factor modification and management. Recurrent episode of vision loss in the same eye done as soon as possible, but can be delayed for 1 to 2 weeks, compromising the test results. Treatment is not delayed as secondary involvement can occur. In intravenous methylprednisolone, 1 gram per day for first 3 to 5 days, followed by oral prednisolone, 1 mg per kg per day, up to 100 milligram per day can be started, tapering slowly over 12 months or more, depending on the course response. Adjunctive daily aspirin can also be prescribed. These are the differentiating features between the arteritic and the non-arteritic form. Other causes for the optic neuropathy are the diabetic papillopathy, papillophlebitis as seen in central retinal vein occlusion, compressive lesions like the optic nerve sheath meningioma and the optic pathway glioma, in which the eyelid edema, eyelid retraction, lid-lag proptosis, ptosis, ophthalmoplegia, and the optic nerve head may be normal or slightly atrophic with optociliary shunt pressures and the choroidal folds. Infiltrative like inflammatory, infectious, or the neoplastic lesions of the optic nerve. Liver hereditary optic neuropathy, it affects mainly boys and men aged from the 15 to 35 years. The possible range is 1 to 86 years of age. Patient is characterized by the acute painless, sequential, and severe vision loss, less than 20 by 2200. The visual field is seen as the visual field defect is seen as central or centrocecal visual field impairment, hyperemia, elevation of optic nerve head with thickening of peripapillary retina and telangiectasia, and the torsity of blood vessels is shown as seen in this figure. And the visual field defect also shows the centrocecal scotoma. Fellow eye involvement can be longer, up to 8 years, and no treatment is not known, and idabenone is still in controversy. Toxic substances and nutritional deficiency optic neuropathy, which is characterized by the gradual, progressive and painless vision loss that is bilateral and symmetric. There is subtle depression of central vision, this sensitivity on Amsler grid or perimetric testing focused mainly in central 10 degree. Decrease in visual acuity and color vision with central scotoma is seen. In rare cases, optic nerve may present with mild to moderate edema on presentation. Vitamin deficiency and drug toxicity is seen. In this case, the temporal pallor is seen in both bilateral eye. The toxic substances are methanol, ethylene glycol, organic solvents, lead especially in children, tobacco use, drugs like ethambutol, linezolid, amidaron, disulfiram, ciprofloxacin, cisplatin, vincristine, amiodarone, tumor necrosis factor, interferon, and decrease in vitamin B12, copper, folate, or thiamine. Prognosis is usually good if the optic atrophy is not supervened, but the prognosis is usually highly variable, may take up to several months for the vision recovery. Traumatic optic neuropathy, it results from the trauma to the head, orbit, or globe. Direct trauma is very less frequent than the indirect optic nerve injury. Direct traumatic optic neuropathy is caused by the injury to the optic nerve head itself and by laceration with the bony fragments or the other foreign bodies. Compressive lesions secondary to intraorbital or intracranial hemorrhage. Indirect optic neuropathy is relatively due to minor head injury, the frontal or maxillary bone involvement, and transmitted forces damage optic nerve at orbital apex. And the pathology is the shear forces on the optic nerve head and the optic nerve, and the possibly is vascular supply to the optic canal with avulsion of the nerve may occur. The figure shows the entrapment of the bony fragments in the left optic canal. Vision loss is typically immediate and often severe. 24 to 86% of patients have NPL at presentation. RAPD is usually present. Optic nerve usually appears normal at onset, but becomes pale within 4 to 6 weeks. Vision recovery is poor. Numerous reports have shown that the spontaneous recovery in some visual function. The International Optic Nerve Trauma study have shown no clear benefit with IV steroid or the optic nanol decompression. The CRASH study was also terminated due to the high mortality rate in high dose intravenous in methylprednisolone 2 gram bolus followed by 0.4 gram for 48 hours in 20 ml infusion was started within 8 hours of head trauma than in the placebo group. Optic disc drusen, they are the hyaline or the colloid bodies, refractile, often calcified nodules located within the optic nerve. The small in diameter with indistinct or irregular margin. The optic disc drusen is seen in the superiorly in the fundus disc examination, and in nasal step as in Humphrey. The B scan shows the increased hyperreflectivity shadow in the B scan, and the autofluorescence also shows the optic disc drusen. And similarly in CT scan also the hyperreflective calcified nodule is seen. Optic nerve hyperplasia, the minimal visual field or the visual acuity loss from 25-15 to NPL can be seen. 56 to 92% of the patient are bilateral. Pale gray or hyperemic optic nerve is seen surrounded by yellowish peripapillary halo border with increased or decreased pigmentation, known as a double ring sign. It is maybe associated with skull-based defects, maybe associated with basal encephalocele. The figure shows the small discs surrounded by the yellowish halo with increased or decreased pigmentation. Tilted disc syndrome, in which the infranasal colobomatous excavation of the nerve tissue with thinning of the adjacent RP and the choroid is seen. Visual field defect failure to respect the vertical midline, and partial improvement with the refractive correction is seen. In this figure, the A and B shows the bilateral superior defect that do not respect the vertical midline, and C and D shows the tilted optic disc. Colobomas of the optic nerve may result from the incomplete closure of the hemorrhagic fissure, and usually it occurs inferiorly. Optic nerve pit, depression of the optic nerve pit surface that is often gray, yellowish, and white infratemporally. Morning glow syndrome is characterized by the funnel sepate staphylomatous excavation of the enlarged optic nerve and the peripapillary retina. Talking about the chiasmal lesions, mainly the temporal defects that align within along the vertical meridian is seen. The most common defect is bitemporal defect, as we can see in this figure shown by the figure 3, bitemporal hemianopia. The patient is characterized by the gradual progressive bilateral vision loss, often asymmetric vision loss, and affected optic nerve is characterized by the decreased vision, dyschronoptopsia, and the RAPD on the affected side. Optic nerve edema is not common. With progressive damage, atrophy is seen often in temporal portion, and cupping may increase. Compressive lesions are common or infiltrative. The A and B figure shows the bitemporal depression that is worse superiorly with margination around the vertical midline. Visual field other pattern in chiasmal lesions are region if they include injury and optic nerve at the junction with the optic chiasma, shown in this figure by the 2. It leads to the junctional scotoma due to disruption of the vulvar knee fibers disruption, characterized by the decreased vision, central visual field loss occur in the ipsilateral eye, and the temporal hemianopia develops in the opposite eye, as shown in the figure shown by the number 2. And if the unilateral temporal hemianopia is only seen that respect the vertical midline with no involvement of visual field in the opposite eye, it is known as the junctional scotoma of the tracker, but it is rare. Etiology can be extrinsic or intrinsic. Extrinsic can be pituitary adenoma, apoplexy, that is hemorrhage in the pituitary adenoma, paracellular meningioma, cranopharyngioma, paracellular internal carotid artery aneurysm, other CNS mass lesion that can produce the third ventricle dilatation. Treatment depends on age, nature, location and extent of tumor, hormonal activity, and symptom severity, particularly the extent of vision loss. Observation only if the vision field is normal. Surgery, after surgery, vision recovery is usually rapid. Medical therapy, bromocriptine or carbapenem for prolactin secreting hormone, shrinks the tumor and improves visual function in responsive case. Radiation therapy as adjuncting therapy or the primary therapy is also followed. Prognosis is poor if papillary retinal fiber thickness and the OCT scan is less than 75 micrometer. Visual acuity, visual field, and color vision testing should be performed every 2 to 3 months after treatment and at intervals then after 6 to 12 months. And periodic neuroimaging is essential. Intrinsic lesions are infectious, tuberculosis, Lyme disease, inflammation, sarcoidosis, multiple sclerosis, neoplasm that can be primary or secondary, significant closed trauma, paracellular radiation therapy, or ischemia, which is uncommon because of its collateral blood supply by the enterochoroidal or the intercommunicating artery. In chapter 5, the patient with the visual dysfunction due to the retrochiasmal disease. On introduction, diseases involving the posterior or the retrochiasmal visual pathway involves the lesion of optic tract, lateral geniculate nucleus, body, optic radiation, occipital lobe, visual cortex, and its associated areas. The lesion is homonymous visual field defect respecting the visual vertical midline. Stroke is the most common cause, followed by the traumatic brain injury and the tumor. If it involves the optic tract, here it is shown by the four. The homonymous defect in the midline hemifield is in contralateral to the affected optic tract. As if the right optic tract is involved, then we can see the left homonymous hemianopia as shown in the figure. And the causes are aneurysm and the tumor, which are common, followed by inflammatory and demyelinating disorder, which are occasionally occur. And ischemic lesions are uncommon, but they can result from the occlusion of enterochoroidal artery. The other optic visual pattern, other defect is the visual bow tie optic atrophy, which involves the cross-retinal fibers, the papillomacular fibers, and the nasal radiated fibers in the contralateral eye, causing atrophy of the corresponding nasal and temporal horizontal portion of the optic nerve head, known as band or bow tie optic atrophy, as shown in this figure by the red dashed line of the right eye. If the left optic tract is involved, the right bow tie or the bow tie optic atrophy is seen as shown in the figure D. Mild RPT is seen in the contralateral eye. Atrophy of the ipsilateral eye involves only the RP temporal fibers characterized by the vertical bow tie atrophy. If the lateral geniculate nucleus is involved, as shown in the figure A, disruption of the posterior lateral choroidal artery, branch of the posterior choroidal artery, the congruous horizontal sectaronopia is seen, and the disruption of the enterochoroidal artery, branch of the middle cerebral artery, loss of the upper and lower homonymous quadrant is seen, known as the quadruple sectaronopia, with preservation of the horizontal base as seen in the figure. Optic radiation of the temporal lobe, as seen in the figure, as demarcated by the red lines. Infrared visual fibers, they course anteriorly, then laterally and posteriorly to the middle lobe of the temporal lobe, and the visual field defect is seen as the superior incongruous homonymous visual field defect, contralateral to the lesion, that is seen as the pie in the sky lesion, as shown in the second figure, and the defects are usually tumors within the temporal lobe. Optic radiation of the parietal lobe, the fibers are indicated by the blue lines. If the superior fibers are involved, the contralateral inferior incongruous homonymous hemianoptic defect is seen as the pie in the floor, often results from the stroke or neoplasm. There is also reduced optokinetic response with the target moving towards the affected side. The figure is the 8 and 9 shows the involvement of the pie in the sky and pie in the floor defect. Optic radiation of the occipital lobe, the fibers are arranged as central or peripheral. The central fibers course to the occipital tip, whereas peripheral fibers course to the anteromedial cortex. The defect are seen as congruous homonymous hemianopia, possibly sparing the fixation region, as seen in this figure, after the involvement of the occipital lobe infarction. Homonymous quadrantopia, superior or inferior, respecting the horizontal meridian, can also be seen. Monocular field defect with temporal crescent may be seen with involvement of the anterior portion of the occipital lobe. Homonymous defect sparing the temporal crescent is seen. Optic radiation of the occipital lobe, Usually is characterized by the normal pupillar responses and optic nerve appearance, unformed hallucination like the spots, primary visual cortex involvement due to neoplasm, migraine, or the drugs, formed hallucination like the stars. Like the patient will see like stars-like thing due to the lesion in the striated cortex or the temporal lobe. Statico-kinetic dissociation or the return phenomena can be seen in which the patient sees the moving object. Cortical visual impairment, it presents with the variety of visual symptoms, cerebral alexia, visual agnosia, and the visual spatial dysfunction. Visual acuity is relatively preserved, and the diagnosis of CVI may be missed or delayed. Alzheimer's disease is the frequent cause of CVI. Neuroimaging is done to rule out structural or the vascular lesion. Visual rehabilitation is must to improve the visual function and independence. Peripheral sectoral prism eyeglasses, small high power prism on the lens epilateral to the homonymous hemianopia may be tried. Books on tape, text recognition, bright marker to indicate the margin on the side of visual field loss, and the straight is to follow the lines of the text. Hemianopic dyslexia, psychiatric training to make the projective saccades, laterally scrolling text can be tried. With this, I want to conclude my presentation with take-home message that the pre-chiasmal lesions cause monocular vision loss. Chiasmal and the post-chiasmal lesion cause binocular vision loss, with the very rare exception of the temporal crescent syndrome. Retrochiasmal lesion result in visual field loss that respect the vertical meridian. The ophthalmologist's role in managing the cellular and paracellular tumor is crucial because vision loss may be the first sign for the occurrence and the recurrence of the tumor. Thank you. Now I would like to request Dr. Keepa ma'am to continue the presentation.
Good evening, everyone. I'm Dr. Keepa from Tilganga Institute of Ophthalmology. I'm going to share about talk about the chapter 6 to 8. I'll be talking about the 3 chapters. First, the patient with transient loss of vision. Transient loss of vision is the sudden loss of visual function, partial or complete in one or both eyes that last less than 24 hours. It can be monocular transient loss of vision or binocular transient loss of vision. The most important cause of monocular transient loss of vision is acute retinal ischemia due to temporary occlusion of the central retinal artery or its branches by emboli. The most common cause of binocular transient loss of vision is migraine. Monocular versus binocular transient loss of vision is important for localizing the causative lesion. The monocular loss usually occurs from the pre-chiasmal problem, like from the cornea to the optic nerve. Binocular loss will be caused by the chiasmal or retrochiasmal problem. Regarding age, monocular transient loss of vision in old age patient usually caused by the cerebrovascular disease. Patients with who are older than 50 years, DCA or giant cell arteritis should be suspected. In younger patients, though uncommon, central retinal artery vasospasm would be the common cause. And in binocular cause, migraine, the most common is migraine, and the most exception is eclampsia in the pregnant women, which should be considered. Duration of transient vision loss can give us the clue about the transient loss of vision, like lasting seconds. Can be caused by papilledema and sometimes optic dystrusion. Several minutes, less than 15 minutes from retinal ischemia like GCA. Seconds to hour, central retinal artery vasospasm. Up to 30 minutes, ocular hypoperfusion or venous insufficiency. Few seconds can be caused by occipital seizures. And 20 to 30 minutes is a typical of migraine. The pattern we talk about is in retinal emboli, there will be descending or ascending curtain-like in one eye. Usually the altitudinal aspect should be strongly suggest retinal emboli. Vasospasm, pigment dispersion syndrome or demyelinating disease cause vision loss or disturbance precipitated by exercise, like in optic neuritis, Uthoff's phenomenon. Posterior circulation ischemia causes complete binocular transient loss of vision due to the cortical visual impairment. Occipital lobe ischemia, there will be whiteout of the vision in the both eyes without positive visual phenomena. Migraine can cause positive visual phenomena and headache. In increased intracranial pressure, there will be associated symptoms like persistent headache and pulsatile tinnitus. In GCA, greater than 50 years older age, they might have jaw claudication, headache, and scalp tenderness. Presence of other neurological signs and symptoms can help us localize the vascular territory involved, like loss of consciousness, dizziness, diplopia, in cerebral ischemia, in the posterior circulation. Similarly, focal weakness contralateral to the monocular transient loss of vision or aphasia can occur in cerebral due to cerebral ischemia in the anterior circulation. Predisposing conditions can be autonomous diseases, diabetes, hypertension, dyslipidemia, smoking, sleep apnea, conditions suggesting the cardiac source of emboli, intravenous drug use, family history or personal history of clotting disorders, systemic cancer, and the vasculitis. Detailed examination should be done. Ocular examinations like best corrected visual acuity, color vision, pupillary examination, especially RAPD or Horner's syndrome, slit lamp examination, dilated fundus examination, intraocular pressure, automated perimetry, monocular transient loss of vision. It can be of ocular origin, could be caused by the orbital origin or the vascular. The ocular causes could be caused by the tear film abnormalities. Due to these can be resolved by the frequent blinking or use of artificial tear. Other causes like uveitis, glaucoma, hyphema syndrome, and AC abnormalities like narrow angle IOL robbing of the iris, pigment dispersion can also cause. And the posterior segment abnormalities like macular abnormalities, optic dystrusion, or optic nerve head swelling. Orbital cause like foreign bodies and tumors like meningioma, hemangioma can cause by compression and ischemia to the orbit. Vascular causes like emboli, vasculitis, hypoperfusion, hyperviscosity, and hypercoagulability. Vascular causes can, like amaurosis fugax, refers specifically to the retinal transient ischemic attack. It is a form of ischemic attack of the anterior circulation that results from the decreased blood flow in the ophthalmic branches of the internal carotid artery. As I have already said, retinal emboli can cause acute painless vision loss in one eye, often describing as a descending or ascending pattern, and it resolves over a few minutes. Three most common types of emboli are cholesterol embolus, platelet fibrin embolus, calcific embolus. Cholesterol embolus usually located at the major bifurcations, usually common or internal carotid artery. Platelet fibrins usually are mobile and can lodge along the course of the vessels, especially the walls of atherosclerotic vessels like heart and valves. Calcium, chalky white in appearance, and they can be found in the heart or great vessels. Other emboli results from cardiac tumors like myxoma, post-trauma, administration of depot drugs like corticosteroids. In those cases, we should do the clinical and lab evaluation like complete vascular and cardiac evaluation, blood pressure, pulse, cardiac auscultation, carotid artery auscultation. If we suspect devastating cerebral stroke, we should refer the patient to the emergency department, especially affiliated with the stroke center. Imaging is quite helpful, so we should do duplex carotid ultrasonography, MRA, CTA, helps us to visualize and characterization of the plaque and the surrounding arterial wall. These imaging techniques are extremely useful for detecting the internal carotid artery dissection. As we can see here in this picture of the MRA, there is a high-grade stenosis at the bifurcation point of the cervical internal carotid artery. So management pathway for the monocular transient loss of vision, we should first exclude ocular and orbital causes. Then if the patient is older than 50 years, we should exclude giant cell arteritis and work for the source of emboli and CNS ischemia. Transient loss of vision is a medical emergency. So we should, it has a high risk of early ischemic stroke, cerebral stroke, or other cardiovascular events. Patients with TIA, 10% to 15% have cerebral stroke within 90 days. Approximately 50% of these strokes can occur within 48 hours. The treatment should be initiated by the neurologist, stroke neurologist. Other additional systemic causes are vasculitis. In vasculitis greater than 50 years, GCS should be suspected, and these patients will have signs and symptoms like headache, scalp tenderness, jaw claudication. For these cases, we should do the blood investigations like ESR, CRP, complete blood count. High-dose corticosteroids can prevent the progression to permanent vision loss. Ocular hypoperfusion, central retinal vein occlusion can cause transient loss of vision, which lasts from seconds to minutes, with full recovery to normal afterwards. Changing in posture from sitting to standing position can occur due to severe stenosis of the great vessels or GCA. Ocular ischemic syndrome is a hypotensive ischemic retinopathy with low retinal artery pressure, poor perfusion. As we can see here in this picture, there is a mid-peripheral dot blot retinal hemorrhages, dilated non-tortuous retinal veins, thinning of the artery, and microaneurysms. Recurrent pain of orbital pain that improves when the patient lie down, suggestive of carotid occlusive disease. In early stage, the transient loss of vision occurs on exposure to the bright light. In severe cases, it might be confused with a chronic intraocular inflammation like decreased vision, red, painful eye with episcleral vascular hyperemia, aqueous flare, IOP may be low, normal, or high, and neovascularization can occur. Treatment is often challenging, so the early detection is crucial. If its chronic hyperperfusion develops, it is unlikely to improve. Other additional systemic causes like vasospasm can cause by the central retinal artery vasospasm as a painless, severe monoocular transient loss of vision. Hyperviscosity can occur due to the increased serum viscosity resulting from the elevated protein level, like in multiple myeloma, polycythemia, leukemia, myeloproliferative disorders. Hypercoagulability can result from the acquired hereditary conditions. Binocular transient loss of vision, the migraine is the most common cause. It causes visual aura, which is homonymous hemianopic. It causes homonymous hemianopic defect. The homonymous cotopa bounded by the zigzag shimmering, colorful or silvery image, which enlarges over several minutes and completes and then gradually disappears within 5 to 60 minutes. Other causes are occipital mass lesions like tumor, AV malformation, and there is an associated headache, which the symptoms occur in the same side. Occipital ischemia can be caused due to the occipital lobe distribution to the basilar artery or posterior cerebral artery. And the patients have headache, especially in the brow, contralateral to hemianopia. Occipital seizure can cause by the tumor, AV malformation, or the structural abnormality due to trauma. Patients with hallucination, illusion, and disorder of high cortical function. Illusion is the false perception of visual stimuli that disappears with the eye closure. Hallucination is the subjective perception of the object or event, even when no visual stimuli is present, and it usually does not disappear with the eye closure. Disorders of higher cortical function can affect interpretation of the visual input and cause difficulty with visual tasks despite intact visual acuity and visual field. The assessment should be, we should do the thorough ocular examination along with the patient's mental status. Past medical history and medication list should be obtained. Hallucination and illusions should be distinguished from the perception of entoptic phenomenon like vitreous floaters, retinal vessels illuminated obliquely, white blood cells circulating in the retina. Causes of illusions could be optical, usually in the refractive media, like irregularity in the refractive elements, alteration in the tear film, corneal abnormalities like keratoconus, corneal edema, scarring, peripheral iridotomy or iridectomy. Retinal causes usually caused by the macular disorders, which cause metamorphopsia due to the epiretinal membrane, macular edema, macular hole, or subretinal diseases. Intraretinal edema can be caused also, where there will be the retinal elements will be pushed apart and cause micropsia. The perceived image will be smaller, and also if the photoreceptors are pushed together, micropsia can occur. Macropsia, the perceived image will be enlarged. Retina may be the source of dyschromatopsia associated with the drug side effects like digoxin can cause yellowing of the vision. Sildenafil can cause blue tinge vision. Vitamin A deficiency can cause choroidal or retinal ischemia, which leads to persistent after image or dazzle. Optic nerve origins can cause episode after the episode of demyelinating optic neuritis. There will be relative conduction delay within the afferent optic nerve, which may lead to altered perception of motion, causing Pulfrim's phenomenon. Cortical origin can cause, like in occipital pathology, they may alter the perceived shape and position of the object and change the perception of motion, causing color vision loss or induce multiplicity of the images. Parietal lobe abnormalities can cause disorders of visual perceptions like micropsia, macropsia, teleopsia, palopsia, or cerebral polyopia. Hallucinations may originate anywhere along the visual pathway, but most commonly within the retina or visual cortex. It can be formed like real objects or unformed like lights, spots, dots, or geometric pattern. Ocular origins would be vitreous detachment with persistent vitreoretinal adhesions, which may produce photopsia or vertical white flashes. These are often apparent in the dark environment and may induce saccades. Optic nerve origin. Optic neuritis often produces phosphine, which are flashes of light induced by the eye movement or dark setting. Patients with subacute or long-standing optic neuropathy may experience sound-induced photoisms. These photoisms occurs because of thalamic dysfunction. Cortical origin can cause palinopsia, which is the unusual cortical phenomena, may occur due to the disorders of the both dominant and non-dominant temporal, parietal, or occipital lobes. Palinopsia is the visual perception after removal of the original stimuli. As we can see in this picture, there is the image. After image is perceived, seeing in the same visual field. Aura and brief intermediate hallucinations due to migraine. There will be abnormal excitatory activity in cerebral cortex. And there may be tachypsia, false sensation of motion, false perception of color, micropsia and macropsia, which cause Alice in Wonderland effect. Persistent positive visual phenomena appears as a snow television static dot, black or white or colored rain-like pattern affecting the entire visual field. Sleep-associated visual hallucinations is usually caused due to insomnia or is excessive daytime sleeping. Hypnagogic is vivid perception of experience occur at the sleep onset. Hypnopompic is the vivid perception that occurs during awakening. Other associated vision loss can be caused by Charles Bonnet syndrome, where the patient have a clear sensorium and realize that the hallucinations are not real, and it is caused in the ARMD patients, glaucoma, diabetic retinopathy, and cerebral infarction. Disruption of central nervous system function causes hallucination, which are associated with the lesion, which are visible in neuroimaging, like stroke, tumor, congenital malformations. Other association are neurodegenerative diseases like Parkinson's disease, Lewy body dementia, Alzheimer's disease, disorders of the higher cortical function. The common causes are stroke and tumor for focal lesions. Posterior cortical atrophy is due to neurodegenerative conditions. Achinopsia is the disorder of recognition caused by the pathology affecting the dorsal pathway to the area of V5 and is also known as the middle temporal area. It is a loss of perception of the visual motion, but the patient still retains the perception of the form, texture, and color. Alexia without agraphia can occur when the splenium of the corpus callosum is damaged. Alexia is the inability to read, and agraphia is the inability to write. Cerebral achromatopsia can also occur due to the bilateral inferior occipito-temporal lobe lesions. The patients cannot match colors or order them according to the hue. Object agnosia. The patient with object agnosia can identify objects by touch or description, but cannot by sight. It is caused by the lesion in the occipital lobe to the area of the temporal lobe. Prosopagnosia is the inability to recognize familiar faces. Affected patients usually have difficulty performing other visual memory tasks, and it usually occurs with the bilateral inferior occipito-temporal lobe damage. Simultagnosia is the failure to interpret the multiple elements seen to form the total picture, such as parietal lobe dysfunction. Here we can see in this picture, the patient with simultagnosia is asked to describe. When asked to describe the picture, he can only describe one part of the scene, but cannot appreciate the large scene. Balance syndrome is the result from the bilateral occipito-parietal lesions. It is a triad of simultagnosia, optic ataxia, and acquired oculomotor apraxia. Disorder of awareness of vision or visual deficit. Anton syndrome is a cortical visual impairment where patient denies having vision problem. It is caused by the bilateral occipital infarction. Redox phenomenon, there is a preservation of perception of motion in the blind hemifield and is also known as staticokinetic dissociation. In this phenomenon, patient can see the moving target but can't see the static target. Blind sight is the cortical blind patient may have unconscious rudimentary visual perception. Hemispatial neglected patient does not acknowledge seeing objects in one hemifield. Patient with abnormal ocular motility or diplopia. Diplopia is the disruption of infranuclear or internuclear pathway of efferent visual system. Efferent visual system controls the ocular movements. Ocular movement system consists of supranuclear pathway and infranuclear pathway. Supranuclear lesions can affect both eyes symmetrically. The pattern of symmetric dysfunction usually do not produce diplopia. Infranuclear disorders affect eyes differently. So the infranuclear lesions usually cause diplopia. We should take the detailed history of the patient. If the diplopia is monocular or binocular, is the diplopia horizontal, vertical, oblique, or torsional? Is it commitant, like same in all field of gaze, or incommitant? Does it vary with gaze direction? Is the diplopia constant, intermittent, or variable? Time of onset, duration, and modifying factors should be noted, and any history of malignancy, trauma, prior strabismus surgery, thyroid disease, or generalized weakness should be asked. We should do the thorough physical examination, especially the movement of the eyes should be assessed in the all position of gaze, both individually and together in ductions and version. Commitant misalignment is usually more common in congenital strabismus, whereas incommitant misalignment suggests acquired disorder. And the diplopia we should distinguish monocular if the diplopia is monocular or binocular. Monocular diplopia usually occurs due to the refractive media problem, like refractive error, uncorrected astigmatism, corneal irregularities like keratoconus, tear film issues, cataract, maculopathies. We can use Maddox rod in order to measure the diplopia. Single Maddox rod test can be done to distinguish if it's latent or manifest strabismus. Is it the diplopia is vertical or horizontal? And the double Maddox rod is usually help us to measure the torsion. We should also differentiate paratic and restrictive syndromes. Usually it can be distinguished by assessing the saccades, but if it does not provide answer, we can do the force reduction test. Here we can see in this picture, after putting the topical anesthesia, grab the conjunctiva in the limbus to the toothed forceps and move the eyeball towards the direction of the limitation. And if the limitation is if the eyeball moves freely, then it is paratic, and if it does not, then it is restricted. Localization of the potential lesions are important. Anatomical localization will detect the patient's evaluation and including the imaging modality and differential diagnosis. Supranuclear causes will be talked in the next session. Internuclear causes of diplopia. Internuclear lesion disrupts the medial longitudinal fasciculus, a bundle of fiber that connects the cranial nerve 6 nucleus on one side of the pons to the medial rectus subnucleus of the cranial nerve 3rd on the contralateral side of the midbrain. This type of lesion produces internuclear ophthalmoplegia. There will be the limited or slow adduction in one eye and abducting nystagmus in the fellow eye. Convergence may be spared or disrupted. As you can see in this picture, this is a picture of internuclear ophthalmoplegia of a bilateral. We can see that patient can abduct in both eyes but cannot adduct. 1.5 syndrome is a combination of horizontal gaze palsy and ipsilateral INO. it is caused by the pontine abnormality due to combined lesion of the middle longitudinal fascicle and